হ্যাঁ, আবার একটা আসছে কিন্তু। হ্যাঁ। না, এটা থেকে আর কোনো ক্লিক করব? ওই যে নাম্বার চাচ্ছে আরকি। তাহলে ক্যানসেল করে দিই, না? বেশি ব্যস্ত থাকে। লিপি নাজমুন আসো নাকি? নাজমুন,
হ্যাঁ
প্রেজেন্টাররা আসু।
কেউ আসে না কেন? সবাই তো স্মার্ট, বুঝি না।
একেবারে সবাই নিয়াজ রহমানের মতো ব্যস্ত। মানে নিয়াজ রহমানের মতো এত ব্যস্ত মানুষ শেখ হাসিনাও না।
অনেক
সে
দিদি
অসহ্য লাগে, বিরক্ত লাগে আমার। না না, এটা কি এখন আরো 10 মিনিট কথা কাজ করে তারপর আমি ঢুকবো। আমি 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 যেন একজন মানে কি বলবো আর, মানে আসলেই এগুলি তো রেকর্ডেডও হচ্ছে।
ঢুকছেন না কেন আপনারা? কোথায়? অন্যদেরকে ফোন করেন না ভাই, সবাইকে বলেন।
আফজাল ওই নিয়াজ স্যারের মতো ব্যস্ত আর কি, অপারেশনটা শেষ করে
আমি তো আজকে আগে ঢোকা যাবে কিনা এই জন্য মেইল অন করে বসে আছি।
গরু কোথাকার।
আমি তো মেইল অন করে বসে আছি যে ঢোকা যাবে কিনা আগে, বা কোনো সমস্যা হয় কিনা। 15 মিনিট সময় নিয়ে ঢুকছি আর কি।
আধা ঘন্টা আগের থেকে এটা অন হয়, 1 ঘন্টা আগের থেকে।
আমি বললাম কোনো সমস্যা হয় কিনা।
ওরা ভীষণ পাংচুয়াল এন্ড দে আর ভেরি একটা পর একটা ওয়েবিনার করতেছে না।
ঢুকেন, সবাই ওয়েট করছে।
তুমি আমি ছাড়া কেউ থাকবে না এখানে। কোনো মানে বাংলাদেশ ভিট্রিনারি সোসাইটি মেম্বাররা এক্সপার্ট ইন সার্জারি।
তারিকা, আপনি কি ওই ফরেনারদের ইয়ে করছেন?
হ্যাঁ, ওনারা ঢুকতেছে একটু পরেই। আফজাল, তুমি কি একমাত্র পুরুষ সদস্য? নারীর ক্ষমতায়ন কোন জায়গায়? শেখ হাসিনা সরকার বাংলাদেশের নারীদের
ঢুকেন। ওই যে কি জানি বলে, আমাকে দিছেন তো ক্ষমতা, ফাইনালে দেখা গেল 3 মহিলা জোগাড় করে ফেলছি। আমি বলছি সবাই আমাকে বলবে যে আপনি পার্সিয়ালিটি করছেন, ফিমেলদের দিয়ে।
আমরা কিছু বলি না, চুপচাপ থাকি। শেখ হাসিনার সরকার কেমনে কি বলি,
তার একটু শেয়ার করে দেখি কেমন লাগে।
করো, প্র্যাকটিস করো। সেজন্যই তো দরকার। আমাদের 10 মিনিট সময় আছে, একবার প্র্যাকটিস করো, জাস্ট দিয়ে করো। ওদেরকে বলো, তোমার প্রেজেন্টার থেকে বলো নাজমুন আসতে।
আমার প্রেজেন্টার ফোন করছি। হ্যাঁ হ্যাঁ, ঢুকেন।
ঠিক আছে, মুভ করতেছে।
কোনো ইন্ট্রোডাকশনের দরকার নাই, স্ট্রেট ফরওয়ার্ড ঢুকে যাবেন। হ্যাঁ, মানে কিছু বলতে আমি আপনাদের ইন্ট্রোডাকশন দিব তো, নিজে কোনো ইন্ট্রোডাকশন দেওয়ার দরকার নাই যে আমি আফজাল এই করছি সেই করছি, এসব কিছু বলবেন, আমি বলে দিব এটা। হ্যাঁ,
জাস্ট শুরু করব। টুডে আই এম গোইং টু প্রেজেন্ট মাই কেস।
না, শুধু এরকম যে গুড আফটারনুন বা গুড ইভিনিং, আই এম জাস্ট ডাইরেক্টলি আই এম গোইং টু মাই প্রেজেন্টেশন।
my first case is something like that, এরকম বলে। my case is something এরকম।
আর ব্যাকগ্রাউন্ড কোনো মিউজিক দিচ্ছি না তাইলে? হ্যাঁ,
আবার মিউজিক
দিচ্ছি না। হ্যাঁ, আমি মিউজিকটা নিয়ে এতক্ষণ দেখতেছিলাম যে দিব কি দিব না, এটাই এতক্ষণ দেখতেছিলাম।
ঠিক আছে, আপনি শেয়ার করে ফেলেন স্লাইড অফ।
জি জি। ফার্স্ট প্রেজেন্টেশন কার ম্যাডাম?
আমি ঠিক করলাম যে ফারহানাকে দিব, তারপর আপনাকে। হ্যাঁ, আপনাদের দুজনটা কাছাকাছি তো।
ঠিক আছে
ভাই।
হ্যাঁ,
যে ফারহানা আর ওরটা মোটামুটি একই টাইপের, আরডি করছে ওরা। হ্যাঁ, আর পরের দুজনকে দিব মালিহা আর আইরিনকে।
ঠিক আছে।
ফারহানা কি প্রথম? হ্যাঁ,
ইয়েলো দাও।
কেউ ঢুকছে?
হ্যাঁ, মালিহা পা ঢুকছে।
মালিহার স্ক্রিন শেয়ার হবে তো না? হবে।
মালিহা ক্লিক করে দেখো, একবার একটু প্রেজেন্ট করে দেখো।
মানে স্ক্রিন শেয়ারটা করে দেখেন যে হয় কিনা।
মালিহা স্ক্রিন শেয়ার করে দেখো। হ্যাঁ
স্যার, ও দাঁড়াও, আবার ভুল করছি। এই যে শেয়ার স্ক্রিন। এই যে ওপেন করেন নাই তো আপনি, এখন আপনার ডেস্কটপ আসতেছে। ডেস্কটপ না, ওই কম্পিউটার আসতে হবে। হ্যাঁ
দেখা যাচ্ছে?
ঠিক আছে ঠিক আছে, হ্যাঁ ঠিক আছে। হ্যাঁ 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 বলেন আইরিন।
আসছে। গুড।
গুগলে দেখা যাবে। হ্যাঁ এই
জি আপা। হ্যাঁ
আইরিন কি ঢুকছে? আইরিন বলতেছে ও ঢুকছে।
দাঁড়াও। ও আচ্ছা, একটু আর এদিকে। ও আচ্ছা,
আইরিন আসে নাই তো এখন। দেখি তো আমার 4 জন অ্যাটেন্ডি আসছে। কে? জিয়াউল হাসান মুক্তা, রাজিবুল ইসলাম।
আমি তো এন্ট্রি দেওয়ার কেউ নাই রে। আচ্ছা ঠিক আছে, আপনি ঢুকলেই ঢুকে যাবেন। আছে অ্যারেস্ট ফার্মার লোকজন আছে। হ্যাঁ ওকে অ্যারিস্টোর কেউ আছেন না?
জি ম্যাডাম আছে, ব্যাকগ্রাউন্ডে আছি ম্যাডাম।
হ্যাঁ
আমরা আছি, সমস্যা নেই ম্যাডাম।
ওই যে আইরিন বোধহয় ঢুকতে পারছে না, দেখেন তো ওকে এডমিট করেন।
আচ্ছা ঠিক আছে ম্যাডাম।
ডক্টর আইরিন।
জি ম্যাডাম।
জিয়া ভাই আপনি শুনতে পাচ্ছেন এখন? হ্যালো জিয়া ভাই, শুনতে পাচ্ছেন? হ্যাঁ এবার আপনাকে শুনছি। সাগরের তীর থেকে কিছু হাওয়া নিয়ে আপনি আমাদের জন্য পাঠিয়ে দেন।
আচ্ছা আমাদের পার্টিসিপেন্টরা তো করবে না, মানে ওরা তো কথা বলবে না।
এই জিয়া ভাইকে দেখো না,
শুধু দেখতে পারবে, কথা বলতে পারবে না।
ফ্যান্টাস্টিক স্যার, এই আলোচনা থাকে।
কোথায়?
আরে বাপ রে
নাকি
ভাই, এটা কি ঝাউবনের ভিতরে?
আচ্ছা শুনেন, অ্যারেস্টো কে আছে? মানে বারবার অ্যারেস্টো বলতেছি, নাম বলেন। শুনেন, ওই যে যারা আমাদের দর্শক আর কি, তারা তো কথা বলতে পারবে না, তাই না?
না
পারবে।
যদি অ্যালাউ করা হয় তাহলে পারবে। জি
তুমি দরকার নাই।
আমাদের হোস্ট করে দেন। অ্যারিস্টো আপনি কি আছেন? আপনি নাজমুনকে হোস্ট করে দেন, তাহলে তুমি দেখবা যে নাজমুন তোমার ওই যে অ্যাটেন্ডির মধ্যে যদি কেউ চায় কথা বলতে, তুমি অ্যালাউ টু টক করে দিবে, তাইলেই হয়ে যাবে। তার নামের পাশে গেলে
অলরেডি কো-হোস্ট করে দেওয়া হয়েছে স্যার।
হ্যাঁ, নাজমুনকেও কো-হোস্ট করে দেন, আমাকেও করছেন না?
নাজমুনকে সবাইকে জি করে দেওয়া হয়েছে।
আচ্ছা ব্যাস, এক্সেলেন্ট।
আচ্ছা
সো উইল স্টার্ট বাই 5 মিনিটস। হ্যাঁ, যে ওরা আসলেই কলকাতার ওরা।
নিয়া স্যার তো একটু আবার ফোন দিবেন নাকি?
না আমি আর ফোন দেব না।
হ্যালো, হ্যাঁ আইরিন। আইরিন বলতেছে তো ঢোকার চেষ্টা করছে। আমি আপনাদের দেখতে পাচ্ছি, কিন্তু আমাকে কি দেখতে পাচ্ছেন? না আপনার ভিডিও অন করেন তাহলে।
ম্যাডাম এই যে ঢুকেছে ম্যাডাম।
এবার আসছে, আইরিন আসছে। হ্যাঁ সরোদা, এবার ঢুকে যান আপনারা। হ্যালো, হ্যাঁ আপনি জাস্ট ওই ইমেইলটাকে ক্লিক করলেই হয়ে যাবে।
ক্লিক করলে হবে।
বলে আপনি কি ইমেইল করেছেন? না আপনি আপনার মেইলটা দিয়ে যান দাদা প্লিজ। আপনার ইমেইল আইডিতে ক্লিক করে দিন।
স্যার আপনি, জিয়া স্যার আপনি যখন ভিট্রোরেটিনা সার্জারি নিয়ে কথা বলা শুরু করবেন, আপনি আসেন কি? আপনার আশেপাশের লোকজন তো অজ্ঞান হয়ে যেতে পারে। আপনি বলে যে এগুলো কি বলেন?
আশেপাশে তো দিলা, আর কে থাকবে? জিয়া ভাইয়ের পাশে আর কেউ আছে? জিয়া ভাই কি তারিক রেজা আলী?
আচ্ছা
তারিক রেজা আলী আর তারিক রেজা আলী নাই।
হ্যাঁ এই যে রুদ্দার চলে আসছে।
গুড ইভিনিং তারিক ভাই, জিয়া ভাই।
গুড ইভিনিং।
I'm here.
রূপদা, জিয়া ভাই যে কোথায়, ডু ইউ নো?
Good evening.
I will not tell you. So Saurabh, good evening.
গুড ইভিনিং।
Yeah, bhai.
নমস্কার।
নমস্কার।
নমস্কার, সবাইকে দেখে ভালো লাগতেছে এক ফ্রেমে।
অ্যাকচুয়ালি অনেকদিন বাদে দেখা হচ্ছে।
হ্যাঁ, অনেকদিন পর দেখা হচ্ছে।
ট্রু, ভেরি ট্রু।
তো আইরিন, তুমি কি একবার ট্রাই করে দেখবা তোমার স্ক্রিন শেয়ার হয় কিনা? এখনো 1 মিনিট সময় আছে আমাদের। ইফ ইউ ওয়ান্ট টু।
নিয়াজ স্যারকে
হয়ে গেছে আইরিন হয়ে গেছে।
আর কি ফারহানা আছে? ফারহানা ঢুকে নাই?
ফারহানা, ডিড ইউ এন্টার? ফারহানা কই?
শুরুতে ওই যে কোনো ইন্ট্রোডাকশনের প্রয়োজন নাই, আপনি সরাসরি ঢুকে যাবেন ইয়েতে আপনার প্রেজেন্টেশনে।
এক্সেলেন্ট আইরিন, ঠিক আছে।
ইয়ে কই, ফারহানা কই?
I can see Saurabh. Saurabh, thank you for
স্যার,
coming.
আসসালামু আলাইকুম।
আসসালামু আলাইকুম।
Walaikum salam, Saurabh. Good to see you. Good to see you. Zia.
স্যার, আসসালামু আলাইকুম।
হ্যাঁ, ওয়ালাইকুম সালাম। ওয়ালাইকুম সালাম। কে কে আসছে দেখে নেই। So we have Tarek, Zia, Irene, Mahfouz, Rupak Kamti. Rupak, you are here. Thank you
Yes,
for joining.
yes, Dada.
Oh, good to see you, Rupak. Yeah, Farhana
Thank you.
and Maliha, all our key players are here. I think we can wait a couple of minutes to join. Okay, Najmun, it's your show. Go ahead.
আর 1 মিনিট আছে।
হ্যাঁ।
So we'll start by 7 o'clock. That is 6:30 p.m. India time. So our plan is like that, Rupakda. Our plan is like that. We have 4 presenters. They will present their cases, and after that, you will just have your comments how it could be done in a better way, or how much they have the effort they have given. What are the tips you can give to them, to other retina specialists also? So there will be a very open discussion here.
Okay.
Dr. Nazmun Nahar is our scientific secretary. She will be anchoring the session.
Okay.
Just out of curiosity, we use a variation of machines here in Calcutta. We use some Constellation Goider. Constellation আমরা প্যাক গুলো প্রচুর রিইউজ করি। Do you all use single pack? Reuse করো তোমরা?
আমরা
reuse, obviously. We have to reuse.
I have one issue over here, and I'll ask Niaz also to comment on that. These valve cannulas that we have, ওটা 2-3 বার পরে লিক করতে শুরু করে। Neither the plug stays there, neither it stays proper. So I am sometimes a little old-fashioned. I still do 23 gauge. I have the plug over there. So I was wondering what you all are doing for this plug and cannula thing.
I'll tell you that, Saurabh. Obviously, I face the same problem. After 2 or 3 surgeries, the little valve mechanism, it just goes away and you have an open cannula. So what I do is, the infusion cannula gulo ache na 25 gauge infusion cannula. Ogulote extra onek infusion cannula ache. What I do is, my nurse takes an infusion cannula with a little bit of the tubing. She ties a knot in the tubing, and that is my plug.
Oh,
you see what I do? Infusion cannula take nei, oda tubing take kete fele. We leave 1 inch of the tubing, and in the 1 inch tubing, she just ties the knot. As soon as she ties the knot, nothing will come out.
Great idea.
Egulo onekgulo abar kache ache. Whenever I need to use a plug. Whenever I come out and it's leaking, I just plug it in with these. So I make my own infusion cannula, plug through the infusion cannulas.
I think I understood that, but maybe you can share a small video of that for us to exactly see what you're doing. But it sounds very ingenious, and I now know যে আমি আগের বার যখন করেছিলাম কন্ট্রিবিউশন করেছিলাম, I was told Niaz bhai does lots of gimmicks and scientific changes. I think makes good sense right now. If you can make a small video of that, it'll be very nice for all of us.
So next time, এখন তো ready নেই, I'll show it to you.
Sure. What oil do you all use mainly? In the well-paying cases, what oil do you all use? What make of oil? Silicone oil?
No, আমার এখানে silicone oil, there are 2 silicone oils available in my hospital. One is the oil from Oro Lab, the Oro Lab.
Okay.
অরবিন্দ, আর আমাদের একটা টার্কি থেকে একটা টার্কি অথবা গ্রিস থেকে একটা সিলিকন অয়েল আসে, ওইটা আমরা মাঝে মাঝে পাই। We keep a stock of those. Those are also very good. I think the oro silicon oil is also good. I mean, we've never really had too much of a problem.
Reason I ask that is because I use a lot of this Italian একটা আসে, RS করে একটা আসে, Italian RS oil, and Indian আমাদের ওই অরোসিলটা I am not very, একটা PDMS আসে somewhere, I don't know where it is from, imported oil গুলো, মানে ওই অরোসিল I am a little bit apprehensive, যা হয় I feel even signature তাড়াতাড়ি হয়, so I'm little apprehensive about that one.
আমারও আসে ইটালিয়ানটা সবসময় পাই না, গ্রিক একটা আর একটা ফ্রেঞ্চ বা ফরগেট, ওগুলো দিয়ে মাঝে মাঝে করি। আর এছাড়া most of the time I don't have any other choice than the oro. আর বেশি আমাদের তো ইন্ডিয়ার মধ্যে এত হিউজ মার্কেট না, আমাদের বাংলাদেশের ভেরি স্মল মার্কেট, সো সবাই চায় না এখানে ইনভেস্ট করতে বা আসতে চায় না।
আমরা শুরু করি।
Before we start, Dr. Tarek, আমার মনে হয় একজনের একটা কেস দেখাবার পরেই যদি ডিসকাস করি তখন না হয়ে প্রত্যেকটা কেস ছেড়ে তখন the panel can discuss and then go to the next case. How do you think? Do you think it's feasible?
আমরা ওটি করব। আমরা সবাই মিউটেড থাকবো, যিনি কথা বলবেন শুধু তিনিই কথা বলবেন। একটা প্রেজেন্টেশনের পরে অ্যাঙ্কর যেভাবে যাকে করতে বলে, অলরেডি শি হ্যাজ প্ল্যান্ড ইন দ্যাট ওয়ে, সো শি উইল আস্ক অল অফ আস টু কমেন্ট অন দ্য সার্জারিজ। আই ডোন্ট নো হোয়াট শি উইল ডু। আমি ওইভাবেই ওকে একটা জাস্ট আইডিয়া দিয়েছিলাম স্যার।
Okay, thank you. I will do the same. We will just see first the video of our presenters. Maybe it will take 7 to 8 minutes for each presenter, and after that we'll go for the discussion, and then the next presenter will come. So this is our plan. Okay. We'll take a few questions from our audience also if possible, and then we'll take in discussion with those questions also. So in total we have 1 hour and 30 minutes, and we have only 4 presenters. I think we can use more time on our discussion, and that will be fruitful for us. So should we start?
Sir, আমরা স্টার্ট করে দিই।
Please go ahead.
We are 5 minutes late.
Please go ahead.
Okay, assalamu alaikum and good evening to everyone. Dear audience, this is Dr. Najmun Nahar. On behalf of Bangladesh Retina Society, I welcome you all to today's scientific webinar on retinal surgery, mentor and mentees. Today, we have 4 young and promising retina specialists who are going to present their surgical video. And we are very delighted and happy that we have 5 learned retina specialists, senior retina surgeon today with us, who will discuss and will put comment on our presenters' video, and we will learn in that way. So this is actually a sharing and learning process, I think. So we will try our best to use maximum so that we can learn from this 1.5 hour time. So our audience, let's start. So before going directly to the scientific session, I think I will take the opportunity to introduce our 5 panelists. Though I know that it will take, I can make a whole presentation for each of our learned panelists, but time is always a concern, so I will only briefly introduce them. So Dr. Niyaz Abdurrahman, he is a senior and famous retina specialist in Bangladesh who has actually pioneered and introduced the beer subspecialty in Bangladesh, who has done his MPH from the Johns Hopkins University, Baltimore, Canada, and the Retina Fellowship from the University of British Columbia, Vancouver. So, he is now the managing director and consultant with Retina Bangladesh Eye Hospital, and currently he is the president of Bangladesh Retina Society. So welcome Dr. Niaz Abdurrahman sir to our webinar. So next is
Thank you.
yes. So next is Dr. Tariq Reza Ali, is the Associate Professor in the Department of Ophthalmology, Bangabandhu Sheikh Mujib Medical University, Dhaka. He is also a senior retina specialist in our country. He has done his retina fellowship from L.V. Prasad Eye Institute, Hyderabad. He is an excellent teacher, and he was the mentor of the Retina Fellowship program while he was in the Ispan Islami Eye Institute and Hospital. And he has trained many retina fellows in our country who are now become the retina specialists and doing very good. And currently, Dr. Tariq Reza Ali is the Secretary General of Bangladesh Retina Society and the Treasurer of the Ophthalmic Society of Bangladesh. So thank you, Dr. Tariq Reza, as you are you agreed to be a panelist of our webinar today. Welcome.
Thank you.
Now, Dr. Jiala Hassan Mukta, he is again a senior retina specialist in our country, and he has done his fellowship from the Shankar Nethralaya, India, and now he is working as a consultant, with retina consultant and surgeon in the Bangladesh Eye Hospital. He is not only a retina, he is also a retina surgeon. He is also well known as a phaco surgeon, and he has done his phaco fellowship from Thailand, and currently he is the chairman of scientific committee of Bangladesh Retina Society. So Dr. Jihalu Hassan Mukta, I welcome you to today's webinar. Thank you very much for as you joined with us. So we are, as I mentioned, we are very happy and privileged that two foreign guests are today with us as a panelist. They are renowned retina specialist, Dr. Shaurup Sinha, who is one of the senior ophthalmologists with great surgical skill in the field of retina. He was the former medical director of the Shankar Nethralaya, Kolkata, and now he's working as a director of BBI Foundation and Netralayam Eye Hospital Private Limited, Kolkata. He has done his retina fellowship from the Shankar Nethralaya, Chennai, and then he became a very excellent trainer or mentor, and he has trained many retina fellows from home and abroad who are now become retina specialists, and he always become a very good academic man. He has published many articles in the field of retina and is a regular presenter in the national and international conference, and he has a huge leadership quality as well, who helped set up the retina departments in 2 rural NGO hospitals in India. So Dr. Shaurup Sinha, welcome you to our webinar. We are very happy that you have joined us as a panelist. Thank you very much, Dr. Shaurup Sinha. So Dr. Rupak Kanti Vishwas, he is the senior veterinary surgeon of BBI Foundation and Netralayam Eye Hospital Private Limited, Kolkata. Dr. Shaurup is also a fellow from the Shankar Nethralaya, Chennai, and he is a very good teacher, and he is the recipient of many awards, awards from the American Retina Society, from E-Retina, from the European Retina Society, FIFA award. Executive member and chairman of postgraduate education of the Ophthalmic Society of West Bengal. So Dr. Rupak Kanti Vishwas, I welcome you to today's webinar, and thank you very much as you agreed to join as a panelist to today's session. Thank you, Dr. Ruhman. So,
Thank you and good evening.
yes. So we can now go directly to our presentation. Our first presenter will be Dr. Farhana Yasmin. Dr. Farhana, I would like to invite Dr. Farhana and ask you to get ready with your video. So Dr. Farhana is a junior consultant of the Retina Department of Isfahan Islamia Eye Institute and Hospital. She has done her Retina Fellowship from Isfahan Islamia Eye Institute and Hospital in 2004. 17 or 18 and has done her retina observership from the Arvind Eye Hospital, India. Dr. Farhana. Dr. Farhana. Dr. Farhana, are you ready? Yes.
Please unmute yourself.
Dr. Farhana, we can't hear you. Would you please unmute yourself? Start again, please. Dr. Farhana, can you hear?
Dr. Farhana, unmute yourself, please. We are not hearing you.
She has to restart because.
Yes. We are seeing your desktop.
Farhana, the presentation ta khulo. Just open your presentation.
Open the right sided presentation.
এই জুমটা কিছু করতে হবে না, তোমার জাস্ট প্রেজেন্টেশনটা খুলো, ওই যে উপরে যেখানে ওপেন ইউর প্রেজেন্টেশন। আর তোমার নিজেকে আনমিউট করে নাও, তোমার আগের বার কথা শুনতে পাইনি।
This is a case of total retinal detachment. After wound construction, I am trying to taking the placement of the infusion line carefully by turning off the microscope light to ensure that the infusion line has not slipped, but I was unable to visualize it. Then I construct another port at 2 o'clock position and indent it in both the sides to create maximum visual exposure. Now I can see the retina and choroid is coming out through the infusion line. Although there is a possibility to strike the crystalline lens, but it is better to have proper placement. So I shaped the tissue around the infusion tip and made the tip free in the vitreous cavity. After ensuring that trocar enters the vitreous cavity completely, then I started vitrectomy. During vitrectomy, I saw that there is choroidal detachment. As choroidal detachment is a devastating complication that could occur due to misinterpretation of infusion tip position. So I again checked the infusion line and found that infusion tip is again behind the choroidal tissue. So I again shaped the choroidal tissue around the infusion tip and made the tip free in the vitreous cavity. Now I again started vitrectomy. During vitrectomy, I found a fibrovascular membrane over the disc and I tried to peel it by cutter. I tried to clear the hemorrhage by suction, but its hemorrhagic tendency is increasing and obscuring my view due to profuse bleeding. At this stage, perfluorocarbon heavy liquid is injected over the disc to stop bleeding and continued vitrectomy. I realized that as PFCL is reducing due to vitrectomy, retina is also collapsing. So I injected more PFCL to settle the retina. As the retina is flattened, I started endolaser in multiple rows. And it is completed as 360-degree laser barrels in presence of PFCL. This is followed by direct PFCL silicone oil exchange. Silicone oil is injected, port closed, and I completed the surgery. Madam, should I go for next surgery?
You can go to your second case, please.
Okay, thank you, madam. This is a case of combined surgery, that is phaco with macular hole surgery. After staining, capsulorhexis, and hydrodissection, I made a deep groove. Instrument is down there and split apart. By using chopping technique, bring the nucleus up, emulsified nucleus, and inserted the oil in the bag. The ports are sealed with stromal hydration. During stromal hydration, the iris is prolapsed suddenly through the incision. With the help of the iris repositor, I pushed the iris back into the eye, but my attempt was failed. After filling with viscoelastic, I tried to reposit the iris, but iris prolapse is more marked now. Then I construct another port and did some vitrectomy, that is anterior vitrectomy. I am doing anterior vitrectomy to reduce the intraocular pressure. Now I checked the pressure and felt that the eye becomes relatively soft. The iris is now away from the corneal incision and I put stitches, made the wound secure. For vitrectomy, the first step is PVD creation. So I tried to achieve PVD without staining, but I was failed. After that, the posterior hyaloid face is well delineated in this patient by triamcinolone acetonide crystal. By using active suction of the cutter, PVD induction occurs very easily. After fluid air exchange and brilliant blue staining, I easily created the edge of the flap by finesse loop. Then I hold the ILM flap by ILM forceps and move it all around the circumference. Now I am trying to place the floating flap over the hole. I conserve the flap around the macular hole. After that, I just enlarge the radius of the circumference of that previous peeling. Then I inject PFCL to settle the floating flap over the hole and also avoiding the dislodging of the flap. Now I'm going to the disc, gently aspirating the fluid. I close the cannulas, inject gas, and completed my surgery.
So, thank you, Dr. Farhana. You just unshare your slide. Off your share screen. Thank you, Dr. Farhana Yasmin, for your nice video. And congratulations to you as you have managed this case very nicely. So I think these two cases will we can have a very good discussion on these two. First, whose screen this is?
This my screen, ma'am.
Just a minute, because we will go for discussion. You just off your yes. Thank you very much. Okay, so now this is the time for discussion. We'll have our 5 learned panelists, so we'll go for the discussion. So at first, I like to invite Dr. Rupakanti Biswas. Please put your comment or any tips on this cases as you have seen Dr. Farhana's 2 videos, Dr. Rupakanti.
Yeah, I think Dr. Farhan has managed it very well in both the cases. And the first case was actually sometimes it becomes a challenging case when, especially when you have, the bleeding starts during the intraoperatively. And she has managed it very well. So putting PFCL over that area helps you in both ways. It helps you in stoppage of those bleeding, and it helps you to flatten the retina as well. So she could manage, both the things by one trick. So this is fantastic. The other way of handling it is, you go, you increase the, if you are using the Constellation system, Alcon system, then you can just increase the bottle height, the intraocular pressure, and then it slowly goes down. Other option is that you can do fluid air exchange. Fluid air exchange is also a very good, because once you have this, air contact with this bleeding spot, then the coagulation starts faster. So that is another way of doing it. Otherwise, she managed it very well. And the first complication also, she managed it very well. I hope that there was no preoperative choroidal detachment. So it was intraoperative, and because she has detected it at proper time, so it has managed very well. Fantastic for managing it. Congratulations.
Okay, thank you, Dr. Rupuk. As you mentioned that air fluid exchange can also stop the bleeding. So should the air pressure keep the 25 or 30, or it should be increased like?
No, that time also, yeah, you can have the both effect. You can have the air contact effect, and you can increase it to up to even up to 50, 60 also. If the optic nerve is not compromised, then you can go up to 50, 60 for a few minutes and then again come down.
Thank you very much. Very nice tips. I think everyone, we have learned this, that 3 things: PFCL, we can increase our bottle, IUP, or use the air pressure. Thank you very much, Dr. Rupakanti. I want to go to Dr. Tariq Rizali. Do you want to put any comment on the same video, Dr. Farhan's video? Dr. Tariq.
Thank you, Dr. Nazmoon. Dr. Farhana did managed it very nicely. The first complication, while she was entering the infusion cannula, at first you have to follow the grammar. We do, like our cricket match, that you have to see the infusion port by yourself. If you see that it is not entering, so choroidal detachment is still there. So it was preoperative choroidal detachment. I can feel like that. And how she managed it was nice, that you have to enter through that way and you have to clean it. But you see, again, this infusion cannula was displaced. So it is a common complication. Still, we are managing these cases. So before entering, probably that is steroid, if you use the systemic steroid for a couple of days, probably it could help her to manage preoperative choroidal detachment. That is one thing, but she managed it nicely. This is a common complication. I want to tell it again and again that still our patients are coming late, so we have to face this complication on and off. So while we are using 20 gauge, it was nice to do that is choroidal puncture we could do with MBN knife, but now it is not very easy with our 23 gauge or 25 gauge. So sometimes what I have to do, I have to go to that is pull out the infusion cannula. I'm sorry, that another trocar, and I have to go with that is MVN knife to use it to clean it, the choroidal detachment and choroid and retina to re-enter. Sometimes I have to do in that way. So again, I have to stitch the wound later on. That is one thing, but she managed it very nicely. And what Dr. Rupak already told, that was very nice, that she used silicone, that is PFCL, to minimize the bleeding and others. But I'm not sure whether she could do all the vitrectomy that was needed for retinal detachment surgery. That is one concern about me, that she just put the PFCL. After that, whether she finished the vitrectomy or not, that is one thing. You have to complete your vitrectomy at least up to till that, because you didn't put any buckle, so you have to clean the vitreous till your periphery. The second case, one tips I can tell, one thing I can add, that is ILM pilling. It was not enough to me. You have to, because the that is macula wall was very large. You have to peel it a bit wider way. I feel like that. So this is my comment from myself.
Thank you, Dr. Tartezale. Only one thing you have mentioned, that use the systemic steroid. We can use only if it is pre-operatively we diagnose. But if it is a complication of the perioperative steroid, still do you suggest that post-operatively should you use the steroid or not?
No. That time it is not needed.
So thank you very much, Dr. Tariq Rezali. I want to go to Dr. Saurabh Sinha. Please put your valuable opinion on these two complications, as Dr. Farhana has shown. Dr. Saurabh Sinha, please.
For the first case, I believe all VR surgeons should think like the phaco surgeon. If the pupil is small, put in hooks. Make the people large. Don't be stingy. Don't want to go near cannulas immediately. Hooks are we are not very tuned to using them, but make your people large. Use hooks very liberally for all VR surgeons. One. Second, like Tariq Bhai said, I'm assuming that this is a choroidal detachment peroperatively. Let's leave out preoperatively. Let's say it's peroperatively. If you have gone with your cannula inferotemporally and you are seeing you cannot see it, then take it out from there. Go through supranasally, and with the MVR blade, with the 23 gauge MVR blade, enter through the inferotemporal cannula to clean that area. So instead of going across under the lens, do it from that side. I repeat again: if you cannot see infusion cannula inferotemporally, take it out, put it supranasally where your MVR blade is going in, and clean that side. This may help in some cases. If you have peroperative choroidals, you must drain the choroidals before doing the vitrectomy surgery. You cannot start vitrectomy without doing any choroidals. I think that's absolutely mandatory. Do not proceed. Open the conjunctiva posteriorly, make a small nick over there, drain the choroidal with a 23 gauge MVR blade, put a suture over there, and start the surgery all over again. I am a little confused on what the diagnosis was. Was it a rhegmatic central attachment or was it a CRD? Because why should there be a fibrous polyp over there? In a reg RD, we will not have a fibrous polyp. So the pathology of the disease is not known to me. The break was not sealed. Why would you have detachment? The break has not been sealed. LPS and oil are excellent tools, but they're not forgiving tools. Recurrence is high with these patients. Like Tariq Bhai said, you have not done vitrectomy adequately, you have not put a belt buckle. What is the original pathology? One must understand that first. The sealing of the primary break is very, very important in the RD patient, whether combined and this is definitely not a TRD. I also do not think one should do suction with the cutter for vitreous, any bleeding on the retina. I think it's a little dangerous process. So I would feel one should take it out, put a flute over there and suck with the flute needle and not with the cutter tip. I know a lot of places teach that. I know people do it, but those who are starting, be a little bit slow, change the instrument, go in the flute needle and do suction with that. For the second case, I noticed that the ports were not made first. I think if you're doing a combined surgery and before starting the phaco, make your ports first, because the sections tend to open up and the eyes tend to prolapse. because like I said at the beginning, we reuse our instruments. So our cannulas, trocars are very blunt, and that causes depression of the scleral part of the and the corneal section opens up. So make all 3 ports first. Don't let any fluid in. Do your phaco and then start surgery. This may help in some cases. Thank you so much.
So thank you, Dr. Saurav Sinha. I think this practice I myself also do. I put only the one port and put the infusion cannula, don't open it, and then go for the phaco and then do the other 2. But you are advising do all the 3s. Am I right? Okay, I don't know whether my other learned panelists what they will tell. I can go to them. So I'll go to Dr. Ziaullah Hasan Mukta. Are you there? Are you connected with us, Dr. Zia?
I can't see Dr. Zia here.
Yeah,
Probably
okay, he's not. Yes, he's on the way. So I'll go to Dr. Niaz Abdurrahman. Sir, please put your comment, as already there is a lot of discussion, plus still we want to hear from you.
Thank you, Najmun, and thank you, panelists. All of you have given most of the things that I wanted to say that went through my mind. I just say, as in the last, I've got little amount of space because mostly you have given your comments, but I'll say 1 or 2 very important things which I think everybody should know. First of all, Farhana, good surgery. You're doing great. Inshallah, you'll improve much further because, when we see somebody doing surgery, the basic skill you have got and your handling is good. So I know that you will progress and you'll be a good surgeon, no doubt. Okay, now, I'll tell you something very, very basic that was taught to me when I started doing VR surgery. In those days, you see, I started VR surgery a long time back. It was in the 80s, in the 87, I did the first VR surgery. At that time, there was only one machine in the world in 1987. And we had all 20 gauge and the cutters were slow. So we had to be very careful of what we were doing because the instrumentation was very poor. One thing I was taught, always check the intraocular pressure by your fingers. Okay. Now, in your first case, before starting surgery, I would have found out that this is a soft eyeball. That is one of the reasons, apart from having a big choroidal detachment, that is one of the reasons why your infusion cannula was not going through the choroidal tissue, the ciliary, the pars plana tissue. You see, because the eyeball was soft. In a case like that, my professor taught me something. He told me that at first you firm up the eye, make the eye hard so that the eye is not soft. How I still do it. You take a needle, as we are doing a 25 gauge, you take a 27 gauge needle, or if you're doing 23 gauge, you take a 23 gauge normal hypodermic needle. Injection syringe needle you take the infusion cannula take a khule fellow. On the end of the tubing, you attach this needle, bend the needle, and put this needle through your trocar and cannula till you can see the tip of the needle through your microscope. That is in the center of the vitreous. Now, this needle is very sharp. That is why it will easily puncture. So, choroidal detachment if the eye is soft, the sharp needle will puncture the tissue in the choroidal, the ciliary, the pars plana. So it'll come through, and you can see the tip of the needle in the mid-vitreous. Don't bring it forward to touch the lens, put it in the mid-vitreous, and you allow fluid to go inside the eye. You feel it with the other fingers to see whether the eye has become hard or not. Once the eye is hard, 80% of your, 90% of your problem is gone, because now if you put in any trocar and cannula, it will go through if you don't have a big choroidal detachment. If you do have a choroidal detachment and you have preoperatively you have seen it, you must do something to drain the choroidal detachment. Till today, I will drain a choroidal detachment. If I know that is a choroidal detachment, I'll do a little bit of cut the conjunctiva around 3 to 4 millimeters from the limbus, and I'll still make a slit, and I'll just go in where I think the choroidal detachment is highest, and I just go in with the MVR knife, just go and make a puncture. It will be a big puncture, 20 gauge. I'll puncture, come out, and keep that needle inside the eye, which is creating pressure inside the eye. All the choroidal detachment fluid will come out through that port, and your eye will be hard for you to put in all your things. The choroidal detachment will be gone, and now you can do the surgery easily. So that is the tip I want to give you and our young surgeons. Make the eye hard. Always check the IOP by your fingers. Okay.
Thank
So
you, sir.
that is the tip I'm giving you. And how to do it? Take a needle, go in, sharp needle, go in the mid vitreous, see the needle through your microscope. You don't need your lenses to see it, just directly you can see it through the microscope like this, and let the fluid in and harden up the eye. Okay. That will save you a lot of things. That's one tip I'm giving you. Most of the tips that my friends have given you, I don't want to repeat them. And Tarek has said something very important. It is a retinal detachment. So you must do a good vitrectomy for recurrence. You must find, Dr. Sinha has said, you must try to find where your primary break is. Or else retinal detachment surgery is all or not. You have to find that break, seal it, whatever you want to use, silicone or gas or whatever, you have to find your break. So now I'm going to the next case. The next case is just the reverse. You did a beautiful phaco, but somehow or the other, your intraocular pressure was very high. Like it was soft in that other eye, it was hard in this eye. That is why the iris kept on prolapsing through your wound. In this case, যখনই আমার যদি এরকম হয়, two things, আমার হবে না কেন? Because as soon as I finish my phaco, I will put a stitch there. I will always put a stitch on over there so that the wound is secure. If I don't do it, I mean stitch na dile, if the iris prolapses, I will not reposition the iris. I will take, you must do your at least one port like you have done, one trocar and cannula you put in. Through there, you go in the mid vitreous and you do a little bit of vitrectomy without infusion. Your eye will become soft. The iris will go back easily, make your wounds suture in the wound, and then you start your vitrectomy. Now, what Dr. Saurav has said, that how many ports you want to do preoperatively, that all depends upon how good your trocar is. If you're using a new pack, just make one port. If you have used it many times, you do more than one port because you don't want to deform the eye too much when you do the second and third port. But saying that, even if your trocar is a little blunt, if your eye is very hard, then you can do a nice port. But if it's not very blunt, so ekta korar pore, if I can put in my infusion cannula, I can make the other two ports. Or else you can do the three ports before, depending upon how trocar and cannula is. So those are the two things I want to say. The last one is, as Tarek has also mentioned about the rexis, you could have beautiful surgery you have done, wonderful. I congratulate you. Rexis could have been a little larger, and if you have put in PFCL over there, be very meticulous that you have removed the full PFCL. Now, letting the last drop will stick to the hole where it is. Even if you have an inverted flap there, with the inverted flap, a little bit of PFCL will stick there, doesn't want to come out. So you have to make sure you want to take it out. Oi drop ta ante gele, you can drain out the flap that you've made. So I don't want to put in PFCL too much to do this. If I do put in PFCL, the trick I do is when I start draining it, I will tilt my eyeball. Ami jeta di korchi, I'll tilt my eyeball so that the dependent part of the eyeball is not the macula, it is somewhere in the superior arcade, so that the PFCL rolls forward and the whole PFCL will come out. If it's a large bubble, then you can drain out the whole thing. Those are the two tricks that I'm talking about in these cases. But still, congratulations, good cases. Thank you.
Thank you very much, sir. Thank you very much for all this nice discussion. I thank all the panelists. I think we had a very good discussion. We have learned a lot from this case. So I must congratulate Farhana again for showing us these two video, and she has done actually very nice. So I'll go for the next presenter. So our next presenter will be
Zia is here now. I can see Zia.
Yes, sir. Just আমি জয়েন করলাম।
আচ্ছা ওকে সো
I think
এখন এগুলো দেখো তারপর
similar cases, I think there would be. Dr. Jia can discuss in that. So Dr. Muhammad Afzal Mahfuzullah, he is the assistant professor of Department of Ophthalmology, Bangabandhu Sheikh Mujib Medical University. He has done his fellowship in vitreoretina from the Isfahan Islami Eye Institute and Hospital in 2016, and he has won the best paper award in OSB conference in 2007. So I welcome Dr. Afzal to show your video. Dr. Afzal.
Thank you.
You share your screen, please.
Yes, madam. Today, good evening. Today I'm going to present my case. This is a case of complicated retinal detachment and choroidal detachment, which is previously managed in the other side of the hospital with C3F8 gas and barrage laser, but it is failed. On examination, I have found this case is developed supratemporal regulatory RD with C3F8 gas in the vitreous cavity. So I felt that the eyeball is very soft and detected there is a choroidal detachment also. So I give him systemic steroid for 7 days, but after 7 days I have seen the choroidal detachment is not fully resolved and the RD is developed fully, that is total RD developed. So I decided to plan go for 360 Bell-Buckle surgery with personal vitrectomy surgery. But when I have started after the buckling, then after the buckling, then infusion port is introduced, but infusion cannula is not seen over the vitreous cavity. So for the confirmation, I introduced with the light pipe, but the infusion port is not seen. So I decided to change the infusion port from the inferior temporal part to the superior temporal part. In a reversible view, you can see here the infusion port is reversed from the inferior temporal part to superior temporal part, and here I can see the infusion port. So I again on the infusion cannula, and the eyeball will become hard. So now I am shifted again the infusion port in the inferior temporal part, and then try to understand where the infusion port is. Now I can visualize the infusion port is visible under the tissue. So I decide to cut the tissue so that it can be visualized. In this manner, a little bit hurry because of the existing choroidal detachment with retinal detachment and not visualization of the infusion cannula. At that moment, there is a bit lens touch as the eyeball is soft. Here you can see the cutter cutter probe is touching the posterior part of the lens capsule, and ultimately I can visualize the infusion port, and you can see the infusion cannula is working and eyeball become hard, and now the choroidal detachment is most probably resolving, and I am starting vitrectomy. After vitrectomy, I can try to understand whether full vitrectomy was completely done or not. So I have to ensure that I have to give triamcinolone acetonide and peripheral shaving as well as done to confirmation of the full vitrectomy was properly done or not. And after triamcinolone acetonide wash and vitrectomy, I have seen that almost whole vitrectomy was properly done, and peripheral shaving also done. After peripheral shaving and proper vitrectomy, uh, after that part, I just want to start with the fluid exchange without giving PFCL, as there is a existing choroidal detachment and retinal detachment. I do not want to give PFCL, and this is a retinotomy was done in the inferior nasal part of the teeth, just to wash out the subretinal fluid. After that, fluid exchange, the whole retina is attached, and I'm doing the peripheral barrage laser just around the retinotomy part. And after doing the barrage laser, I am giving whole 360-degree barrage laser to ensure any and that is all any other micro hole present or not, as there is a On examination, I have found there's an inferior temporal microhole and superior nasal part, there's a microhole and an attis. So for the ensurement, I am giving 360-degree barriers are whole part of the peripheral part. And after that, I am giving last infusion and then put silicone oil injection. You can see the whole retina is attached and there is no any other caudals are seen. And just after that, on February 2020, I have done this case. And just after that case, our lockdown is started. So I'm very much worried about this patient, whether about the intraocular pressure, whether any other extra effect occurred. So in here you can see there is a lens touch in the 11 to 15 o'clock position. After 5 months on August 2020, I am again patient come to me and there is a cataract development. So I want to do cataract surgery with PCL implantation with silicone and removal. But I am worried about that lens touch, whether there is any posterior capsular opacity, and this is occurred. So there is a huge posterior capsular opacity. So on that way, I am giving a foldable intraocular lens, but there is a huge posterior capsular opacity. At that time, I want to do YAG laser posterior capsular opacification clearance by cutter, vitrectomy cutter. But I am very much worried about his eye because as there is a previous cortical detachment and there is a complicated surgery, so I am decided not to do any posterior capsular wash by the cutter. So I decided to remove the oil, and after the oil removal of oil and lens implantation, his vision is 618. Patient is happy, but I am not happy as well because there is huge posterior capsular opacity and vision is 618, but I am not happy. I am again patient tell that you have to come after 1 month so that I can do a YAG laser capsulotomy. After 1 month, I have done YAG laser capsulotomy, and after YAG laser capsulotomy, his vision is maintained 6:9, and now I am satisfied about his surgery. Thank you.
Can you please unshare your
okay, madam.
Dr. Afzal? Yes.
Yeah, madam.
Just unshare is okay. Okay. So thank you very much, Dr. Afzal Mahfuzullah. You have shown a very nice case, no doubt. Congratulations for this case. But I think this Farhana's case and your case is a little bit similar. The complication is again the caudal detachment. But I believe our panelists will discuss on it. Before that, I want to tell one thing for our audience. I'm seeing here we have 49 audience participants are seeing this webinar. So I'm requesting everyone, if you have any question, you can put on the question and answer section and we can discuss later on. Before going to Dr. Afzal's videos discussion, I want to say one question which is asked by one retina specialist from Nigeria. He is Dr. Hussain. He was the retina fellow he has completed his retina fellowship from the Isfahan Islamia Eye Institute and Hospital. And now he's working in Nigeria. From there, he is watching this webinar and he has written here that, that how do we manage if you discover that the silicone oil in the eye was not enough 2 weeks after the PPV for the retinal detachment. I hope you can get the question from Dr. Hussain. I'm requesting Dr. Sharoop Sinha, can you go for this question answer of Dr. Hussain? I'm requesting.
Yeah, Dr. Hussain, thank you for the question.
Yes.
So 2 weeks later, I'm assuming my retina is attached. So there are two different situations. The retina is attached and the break was superior. Even if it was inferior, if retina is attached, you don't know anything about it. Okay. So I have never till date re-put silicone oil in an attached retina. I'm not worried. I know it will emulsify quickly because it's a partial fill. If you have a recurrent detachment, you have to anyway go in. So for an underfill of oil, it looks ugly. You have the inferior reflex. You as a surgeon know you've not done a great job, but that's something you have to accept. And I think nothing to be done if it's underfill. If you have no recurrence, keep a more closer follow-up. Be prepared for emulsification. Nothing to be done. That's my take. I have never re-put in oil for an attached retina at 2 weeks.
Okay,
And I totally believe that if 2 weeks retina is stuck, very unlikely that it will jump up from there after 2 weeks. Unlikely.
Okay, so in relation to your answer, I think then you can also tell our audience that how we'll be sure that operatively that our eyeball is actually optimum with the silicone oil. I mean, just
okay. So the advantage of starting in the 20 gauge era, like Niyaz bhai said, was that you've seen it all and done it all. So I now put in the oil myself. I don't leave it to my fellows. I know I'm a little nasty that way, but I've seen it both ways. The fellows put in, when we put in, what happens is the pressures are going to be high, can be underfill. So to answer your question specifically, when I put in, after filling my surgery, if I put in the oil, I will put in the oil under visualization with my light pipe. I keep it decreased. Let's say I finish the surgery and the pressure are 30 in the infusion color. If G is done and as a reg RD, I will start putting in oil from the supratemporal one with my light pipe in my supranasal, and I will keep my air pressure maybe down to 20 now. I'll fill in half the oil, make the air pressure 15, then put in some oil, make it 10, then off the air infusion and keep putting in oil till I can actually visually see that all the air bubble has come out. I will not stop putting in. If I have to done that, sometimes I'm a little lazy, I'm trying to finish quickly, patient moving. If I've come out, I will actually visualize under the microscope to see all the air bubbles coming in. I will again keep putting a little bit of oil, putting a little bit of fluid, take the oil out. And what I tell my fellows right now is that once you put in oil, if it's an overfill, leave your cannula there for some time, keep watching. The oil is coming out slowly by slowly on its own, then it's overfill. That's just one very small trick. And of course, this is assuming that your air fluid, you have no more air coming in. So it's an oil filled dye. Your infusion cannula is closed and your oil has been put in. Wait, don't do any touching, don't do moving of the eye. And like Niyaz bhai said, what I was taught about I teach my fellows is this is hard. If it's like this hard, that is eye is hard. This is okay and this is soft. So I keep telling my fellows, keep doing this all the time and press your eye and see how it is. If it's the nose, you know it's okay.
Yes, so it is optimum. Okay, so very nice tips. I think you can also go.
Yeah, would like to add up of what Dr. Sinha has told.
Yes.
Yeah, I think this is absolutely practical tips what he has told. But most we need to understand that what is the common causes of underfill. So if you have the intraoperative, if you still have the some amount of the choroidal detachment left, that can lead to a underfill. But again, you need to sometimes, if the choroidal detachment and the break is on the choroidal detachment, then you have a bliss in disguise, because that acts as a buckle effect. So you have that choroidal detachment and the break is sitting on that. So you can have a little bit of underfill and you can still get away with that, number one. But most common causes of underfill is that when you are finishing the surgery. So when you take out the the cannula, that time it starts leaking. So even if you do a sutureless vitrectomy with 25 or 23 gauge also, if you see your sutures the ports are leaking and the oil is coming out in the subconjunctival space, please do not hesitate to put a suture there. Even if you do a transconjunctival suture also, absorbable vicryl, that is absolutely fine, and you are justified to do that. Another important factor is that once you do the surgery, your if you have a self-retaining speculum, the pressure of the speculum itself causes some amount of the, you feel that your eye pressure is absolutely fine. The moment you start taking the speculum, you feel that your eye pressure is gone down. So you can titrate once you remove that, you put your last cannula there, and then you titrate at the end and then take out that cannula, and then you can suture it.
Thank you, Dr. Ripok. I think thanks to Dr. Saim for putting this very nice question. We have learned from our learned panelist on this question. So thank you very much again. So now I want to ask our panelists to discuss on the Dr. Afzal's video. So may I request Dr. Rupok, as you are already discussing, so can you just put your comment on Dr. Afzal's
Yeah, I think there is some amount of the overlapping discussion which has already been there. Yeah, so
already
here you have a
yes.
You have a preoperative choroidals here. So compared to the other one, if we think of that was a paroperative. So here the role of steroid, as Dr. Tariq was mentioning, the role of steroid is to reduce the choroidal as well to reduce the inflammation, which is the most important. The failure occurs or the PVR changes occur. The failure occurs due to the PVR changes, and the PVR changes occurs due to the preoperative inflammation per se. So if you have a 7 days of oral steroid, you have the good dose to control the preoperative inflammation, and the success rate goes up by that way, even if your choroidals are not resolved completely. So I mean that the main purpose of giving steroid is to control the inflammation. Even if you are not resolved completely, you can always intraoperatively drain it and then get away of that. Second point, this case, he has managed it very well. But only one point is that I would like to mention that he has the amount of the triamcinolone injected is probably a little more. So if you can give a little less amount of the triamcinolone, it is just you need to stain the vitreous. So the more you give, the visualization goes up, and then initial handling, especially in a detached retina, can cause a little inadvertent problem. So these are the two tips I can.
Nazmun,
yeah, you are.
Yes, thank you. Thank you. Yes, thank you, Dr. Rupok. Actually, yes, these two videos are actually relatively overlapping. I think discussion will be the same. The only question is that should we go for the buckle, bell buckle, along with this pars plana vitrectomy in this type of cases? I think Dr. Tariq can put any comment on this.
No. Actually, we want to hear from Dr. Saurabh and Dr. Rupok.
Okay.
In this case, I will put a
sure.
better.
Okay, you want.
But
okay.
yeah, I will put, but before
you are in favor of putting buckle. Okay, I'm going to Dr. Saurabh.
I will put some that is fluid inside to make it that is hard enough, that eyeball. That is I will definitely put some with 23 gauge cannula. I'll put some fluid to make it stronger, harder. Then I'll put the buckle.
Yeah. Thank you, Dr. Saurabh Sinha. Can you put any comment on this? Should we go for
I'll go back to what both Dr. Tariq sir said and what Dr. Niaz has said earlier. I am a little more, I take a 30 gauge needle and don't go through the cannula, I go through the sclera itself into the vitreous cavity, all the way inside, and inject to tighten the eyeball itself. Recurrent RD, definitely belt buckle. I want to with all guns blazing. No question of not putting a belt buckle. You don't want another recurrence happening, and there's no question of that. Choroidal detachment, definitely silicone oil. Choroidal detachments are very, very poor prognosis for all our patients. They are preoperatively, so definitely silicone oil. 3 more quick points. One, I will never go across my cutter across the eye. Lens touches are phenomenally well known for that. In both the cases, I would strongly suggest not to go across. Go to the same side. Do not go across in phakic patients. It's not a great idea at all. 1, 2. When you're doing a retinotomy, somehow I feel if you have to make a retinotomy, do a supranasal, don't do inferior retinotomy. Because if there's a recurrence that gets lifted up, it's a messy thing. A supranasal retinotomy is always a safer thing to do. Third, when you're doing barrage laser on the periphery, first tighten your belt buckle, then doing the barrage laser on the periphery becomes a little bit easier. You know exactly where to do it. So once you tighten your belt buckle, that's all I can think of. Thank you.
Thank you very much. Actually, we have only half an hour left for this, so we'll go for the next presentation. But before that, I will ask Dr. Ziaullah Hassan, are you hearing us? If you want to put any short comment, you can go for. I think he is on the way. Okay, Dr. Niaz Abdurrahman, sir, if you want to put any short comment.
Because one short comment, everything has been said. Saurabh, thank you for those wonderful tips. I just want to say one thing. Now, at the end of the surgery, you had a posterior capsular opacity. Why didn't you do a primary capsulotomy with your cutter, surgical capsulotomy? Why did you wait 2 months? Why?
This is my question also.
Yeah. Why did you? Amra after cataract, why do we wait? Why do we wait 2-3 months before we do capsulotomy, yak capsulotomy? Why do we wait?
Actually, I'm waiting as there is a previously completed case, choroidal detachment, and
no, you have done your surgery. You have put in silicone oil, right? You have done your surgery. The reason after a regular cataract surgery you wait 2 or 3 months is that you don't want a retinal detachment, because as soon as you do a capsulotomy, the eye behaves as if it is there's an ICCI, intracapsular, so the vitreous can move and it causes retinal detachment. But over here, you've done a vitrectomy. Vitrectomy, the way there's no vitreous in there. Plus, you've put in silicone on. There's no reason for you to wait. You could have done it right there, no problems there. That is what I wanted to say. In a vitrectomized eye, you don't have to wait at all. You can immediately do a capsulotomy.
Yes, I think a very good comment also. So we can go straight away our capsulotomy on the same sitting. Thank you very much. Thank you, Dr. Afzal, once again. So we'll go for the next presenter. Next presenter is Dr. Maliha Sharmin. Dr. Maliha Sharmin, she is a young retina specialist and working as a consultant in Bangladesh Eye Hospital. She has done her fellowship from Isfahan Islami Eye Institute and Hospital in 2014. So I welcome and invite Dr. Maliha. Please go ahead with your video. Maliha, you share your screen. Yes. Dr. Maliha.
This is a case of PDR with fibrovascular proliferation with vitreous hemorrhage, and I done 3-port sclerotomy with 25 case cutter and proceeding core vitrectomy to clear the vitreous hemorrhage. I prefer using 25 case cutter to remove the fibrous band and trying to remove the fibrous band with the cutter. And due to the improved feature of this cutter, we can easily remove the fibrous band from the retina and make segments of the fibrous band and remove the fibrous band from the retina without causing any harm to the retina. And then I give triamcinolone acetonide to stain the vitreous, as vitreous is tightly adherent to the retina in diabetic cases. And I'm trying to remove all the bands. And I remove all the fibrous bands. Previously, and there was some hemorrhage, and previously some laser was done in this case, and I also doing some endo laser, and ear fluid exchange was done, and I complete my surgery with silicone oil injection.
Okay, doctor.
This is my second case. This is a case of advanced diabetic eye disease with peripheral RD. And when I started to induce the PVD, there was a retinal tear. And I stained the vitreous with the triamcinolone acetonide and starting the vitrectomy. And I give PFCL to stabilize the central retina. As I am trying to do PVT, the retinal tear was enlarging more and more. And so I'm trying to do the peripheral vitrectomy with in a shaving mode. but retina was so fragile, and even though there was many retinal tears, and I stopped bleeding with the cautery. And trying to remove the vitreous with the forceps. When I'm trying to remove the vitreous, the RD becomes more and more. The retina was more and more detached. And there was a large fibrous band, and I cannot remove the fibrous band. It was very difficult. So I do a retinotomy there. And doing more peripheral vitrectomy as much as possible. This is a pseudophakic case. I inject more PFCL and doing the peripheral vitrectomy as much as I can. In this case, I didn't put any buckle, as I'm trying to do as much as I can peripheral vitrectomy because this is a pseudophakic case. And I do the peripheral shaving with indentation and fill the vitreous cavity with PFC. Endolaser was done. Yeah, the stage was done and silicone wire was injected.
Maliha, thank you very much, Dr. Maliha. Please unshare your screen. Yes, you have unshared. Thank you very much, and congratulations for showing us this 2 video. So I think we can move on different discussion, as she has shown us the advanced diabetic eye disease. So I have seen here in our question and answer section, we are seeing that many of our retina specialists has put many questions. So one of the question is, how can we prevent retinal break while removing the fibrous band adherent to the retina within the vascular arcade? Number one. And another question was how much the PVD is essential in case of vitrectomy of advanced diabetic eye disease. I think very valid question. So we can go for the discussion. So may I request Dr. Saurav Sinha to go for this answer of these 2 questions. May I request?
Hi, Bilal. I happen to know Bilal, Dr. Bilal personally also, is a good friend of mine. I'll make 3 or 4 very quick comments. I'll answer the questions also. In the meantime, I'd like to ask Dr. Sharmin, in the first case, was there any break?
No, there was no break. No.
Right.
There was no break.
There was no break. So this is the point I try to make all the time. If there's no break and you release all traction, why put in silicone oil? Why put in silicone oil? This is something I'm not able to understand. A lot of our colleagues, a lot of us do it. If you can explain, if somebody can explain to me, if there's no break in an eye, why you put in silicone oil? It's not necessary. It's a TRD. You relieve the traction, leave it at that. It will settle on its own. So silicone oil, diabetic cases, if there is no break, and I repeat myself, diabetic TRDs, Tractional detachments, you don't have a break, you've done a good surgery, do not put a steering column, it's not necessary at all. You have a lot of bleeding inside the eye, very bad prognosis, a lot of vascularity, and that's why you're putting silicone. I can accept that. There's no break, no need of silicone oil. 1, 2. I saw that you did the surgery in. I think in diabetics, it's not a bad idea to increase the magnification to see the retina from much closer up. I think that's a much better idea to decrease. Periphery fine, but see the posterior pole much more careful. It'll make your easier surgery much easier. To answer Dr. Bilal's question, I'm sorry. Dr. Bilal's question has disappeared from here.
No. His question is the. It's not.
Question
there.
was there. It's not there now.
Okay, it was how much PVD is essential.
No, PVD is mandatory to all VR surgery. I think. Period. There's no discussion on that. PVD is mandatory in all VR surgery, and there's no discussion about that. I'll quickly go through the. And there was also a question on the some arcade. I saw that question. Is there any role of preoperative peripheral laser in case of visible advanced diabetic? Yes, there is. But Bilal makes a question of I would always ask and do the peripheral laser as much as possible. What we say, laser to available retina before doing surgery. It decreases surgical time, decreases vascularity if you can get a week 10 days time. So the answer is yes to Bilal's question, Dr. Bilal's question. Laser preoperatively if possible. Preoperative anti-VEGF in case of diabetics, 3 days, 2 days before the surgery. Again, it's expensive business, Avastin, if you're not using. So that can be an option in some patients. Again, decide case to case. But if you're doing surgery, if you're giving preoperative anti-VEGF in diabetic, TRD, you must do the surgery within 2 days. Maximum 3 days, not beyond that. Don't go beyond that.
Okay, thank you. Yes, thank you very much. So I'll go to Dr. Niaz Abdur Rahman. Sir, can you put any comment on this video? Or there is another question from Dr. Sabrina. She is writing, as the large membrane was at the periphery, so was retinectomy needed, or could it be left with good shaving of the vitreous?
Thank you. Good surgery, Maliha. Two very nice surgery. First comment is the first case, it was a very simple membrane and you did a nice surgery. One thing I must tell you that when the membrane involves the optic disc, you don't really want to pull all the membrane away from the disc, because if it starts bleeding from the disc, you cannot cauterize. So I will tend to cut the membrane so that you leave a little tuft at the end over the disc and remove the membrane. So when I'm starting doing the membrane surgery, that membrane which is attached to the disc, I will cut it up somewhere in the middle. And the peripheral part, I can make a hemorrhage there, I can make a retinal tear, I can deal with it later. But if the disc starts bleeding, I've had it. Your case, it was done nicely, there was no disc hemorrhage, fine. Another thing is, you see, you're using a world-class microscope. Why aren't you magnifying, like Shorav is saying? Because you must see clearly what you're doing. Why? Just press your foot, see everything clearly, make your image big so that you can see every little detail. So you must magnify. This is a very valid thing that Shorav has said. All of you, I urge you, I've seen many a time that people use little magnification, but the microscope is there. You paid a crore. The hospital has paid 1 crore rupees to buy this microscope. Why aren't you using it? So we must use that. The other point that also Dr. Sabrina has asked, you had this membrane all in the periphery. Now what the retinotomy that you did is a very large retinotomy. And that retina was attached over there. You ate up a big chunk of the retina, exposed a lot of choroid. So we don't want to expose too much choroid if we cannot. So you shave off as much as possible. See if you leave some membrane, doesn't matter. If the retina settles down, you put laser, it'll stay there. You don't have to do a retinectomy. But if you have to do it as small as possible. So those are the three things that I wanted to say. The first case, and in the second case is that The second case, I want to just say something. You see, you have a retinal detachment, you put in silicone oil, and there are tears in you have put in silicone oil up to a certain part, and you've got tears in the periphery. Okay? You have to do vitrectomy as much as possible. Like Dr. Tariq was saying, do as much vitrectomy as possible. Now, the trick is when you're doing the exchange. When you're doing the exchange, the trick is to do it in stages. What do you have inside the eye? You have the lens or the eye, if it is a pseudophakic, you've got IOL, or you've got a crystalline lens. Just behind, you've got fluid, right? BSS fluid. Then you've got silicone oil. You've got PFCL, all right? And what you want to do is you want to do an air fluid exchange. When you do the air fluid exchange, when you start the air fluid exchange, how do you keep your cannula? Your cannula at first must stay in the fluid, not in the PFCL. You drain out all the fluid, and then you go indent, go to all the tears, drain out the whole subretinal fluid. You make sure before you go to the level of the PFCL, the periphery of the retina is dry. You have to dry the retina. So then you don't have any recurrent retinal detachment. Once you're sure everything is dry, then you dip in the PFCL, take a little bit of PFCL, again see the periphery. If you see any fluid somewhere, you have to drain that fluid before you do the PFCL. So gradually in stages you do the exchange, your retina will stay in place. So those are the two things I wanted to say. Thank you.
Thank you. Thank you very much, Dr. Mia sir. You have discussed a lot. I think we have learned a lot of things from a discussion. So we have running short of time. So still I want to go our other two panelists for a short comment on Dr. Maliha's video. I must Dr. Kanti, Vishesh, can you just put any comment on Dr. Maliha's video? Or Dr. Maliha, do you have any question?
Yes, I want to ask that should I give buckle in this type of case?
Dr.
This
Malia,
is a pseudophakic case. Sorry, sir. This is a pseudophakic case, and I think I can do as much I can by indentation, or as due to pseudophakic case, I can reach more periphery. But in case of emphakic case, should I give buckle? Because there was chance of lens touch.
No. See, the purpose of putting encyclist band is to relieve the traction in the peripheral area. So here in your case, what you have described is there is not much of traction in the peripheral retina, and being pseudophakic, you could have done the good base excision and the peripheral vitrectomy very properly. So I don't think that these kind of cases needs any kind of encyclist band. So even if it is a phakic case, also I will not plan for putting encyclist band like in these kind of cases. Going back a short comment to Dr. Bilal's questions, see there is a only way of doing a good surgery in case of advanced diabetic eye is your patience. So if you make hurry, you will land up in trouble, and you will have more time consuming and your surgical outcome goes off. First and foremost, as Dr. Tariq and all the consultants here are telling about, that complete vitrectomy is a must for any wear surgery. A poorly done wear surgery and poor prognosis cases are not the same. So we need to understand for the youngster that a case who has already a poor prognosis, like a very stage C3 PVR changes, so that is a poor prognosis cases. But a case which is not that poor prognosis, and because of the incomplete vitrectomy and incomplete PVD induction, if the recurrence occur, so that is not accepted. So these are the two different issues. Third point is that if you need to do avoid break in the within the posterior pole by removing this proliferation. So a bimanual surgery is the technique by which you can reduce this. There you can go very precisely. So with the invent of all those new cutter, I think even with the forceps and cutter, you are quite safe enough with the port up. That is quite possible. Otherwise, if you still feel you can use the curved scissor or the straight scissor to do the membrane dissection and then accordingly take away that.
Thank
Thank
you very
you.
much, Dr. Rupuk. I think very good tips for all of us. Thorough vitrectomy is a must, and we can go for the bimanual surgery. Thank you very much. So I think I'm seeing here our Jiaul Hasan sir. I think we are finding you. So can you just have you seen the video? You are on the way. You can go for a short comment. Yes, sir.
Previously, I did silicone oil with PFCL exchange, but nowadays I am mostly doing the gas and air and the silicone and the PFCL exchange.
Okay.
Whatever.
Air, then silicone oil.
Yes, then put the silicone oil. It will be little easier. But in case of the silicone oil PFCL exchange, the pressure will be made more. So if we are doing the combined surgery, more iris prolapse will be there. If
pressure will be high. Pressure is high.
Pressure will be high. If the optic disc is compromised, you may get the more disc compromise.
Okay. Thank you, sir. I think this is another way of exchanging the PFCL and silicone well. Thank you very much for your comment. I'm going to Dr. Tariq Tejali for a very short comment because you are the last person for this. Can you?
Actually, everything is told. One thing I want to tell to Dr. Malia that while you were doing the vitrectomy, your cutter was facing the retina. So you made more and more bricks. So while you are going very close to retina, just turn out the cutter tip towards the vitreous cavity, and then at the time you can reduce your suction. Your suction was probably 500 or like that. You can reduce that if you want to. See, free mobile retina, it tells that vitreous is not there. It is not that retinal detachment is increasing. It tells that there is no vitreous, so it is becoming bullous. So you have to be very cautious in that way. You can just shift to another hand. You could go with your left hand to remove that part of vitreous so that there will be no more that is retinal break, iatrogenic break. And as much as you will be that is experienced, you will reduce your iatrogenic retinal breaks in future. As because you know that more and more retinal breaks creates some more problem of retinal redetachment. That is another one tip I want to give you. Thank you.
Okay. Thank you, Dr. Tariq Tejali. I think we will go for the our last presentation. So. So Dr. Irene Hussain is our today's panel presenter. She is the retina consultant in Bangladesh Eye Hospital. She has done her retina fellowship from Bangladesh Eye Hospital and Institute in 2014, and her observership in vitretina from LV Prasad Eye Institute, India. So I'm requesting Dr. Irene Hussain, please go ahead with your video. Yes. Dr. Irene, we are not seeing your video. Yes. Dr. Irene, we are not hearing you.
Can you see my video?
Yes, we are seeing your slide, but you are not.
Start your slide. Start your slide. Click. Yeah.
Can you see?
Yes.
Yes, we can see. Go ahead.
Today I'll show you my two surgical video. My first case is advanced diabetic eye disease with vitreous hemorrhage and fractional retinal detachment. You can see that there is an advanced diabetic eye disease, the traction membrane all over the posterior pole and vitreous hemorrhage, and I could barely see the retina. First, after doing that core vitrectomy, I was trying to remove the vitreous emorrhage and traction membrane. To do that, I used 25 gauge cutter. Nowadays, we rarely use forceps or scissor because we can use our cutter as a forceps and as a scissor. But trick is to find the plane. After you got the plane, you can cut the traction membrane without harming the underneath retina. And that is exactly what I am doing here. I am trying to cut the traction membrane very gently, very slowly, so I could not harm in underneath retina. And gradually, when I got my plane from the retina, I cut it through the vitrectomy cutter slowly, gently. So from the temporal side, I successfully removed all the traction membrane from the temporal side. After finishing the temporal side, I moved to the nasal side. You can see the nasal side is very complex because there's a detachment, also the traction membrane all over it. And there is very little gap between the traction membrane and the retina. So it was tricky and complex. I use 25 gauge cutter. The port of the 25 gauge cutter is very close to the end of the shaft. So I could go very near to retina, which we couldn't do before. And to do to cut the retina, I pull the traction membrane very gently, very slowly, and multiple times. And each pull, little bit of membrane is severed. When I got the separation and got the proper plane, I was trying to cut the traction membrane without harming the underneath retina. You can see my cutter is trying to find the plane from the detached retina, and very slowly, very gently, I slowly go inside the between the traction membrane and the detached retina. And luckily, I successfully got to manage, uh, remove all the traction membrane without harming the underneath retina. And you can see there is a detached retina and the nasal side, totally nasal side. After completing removing the traction membrane, I found that there's a thick subretinal band just underneath the detached retina. Then I decided to remove that. First, I removed all the blood from the posterior pole to see the condition of the macula. After removing the blood, I did retinotomy and lift up the subretinal band through the forceps. Initially, the retinotomy was very small. When I pulled that subretinal band, it gradually enlarging in size. So, my question to my learned panelist: what could, what should I do to prevent further enlargement of the tear? After removing the thick subretinal band, my surgery was a little bit easy. I did air fluid exchange and did laser and put the silicone well. And my second case is retinal detachment with proliferative vitreoretinopathy. You can see that there is a bullous detachment and traction membrane all over it. It is a combined detachment because you can see the traction all over, and there is also regma. I will show you it later. Also, it is long-standing. You can see that the retina went into fold due to the PVR changes. After doing the core vitrectomy, I was trying to remove the traction membrane from the surface of the retina, and you can see that there is a long blood vessels and traction membrane from the optic disc. Very slowly, very gently, I was trying to lift up the membrane from the surface of the retina, and when I got my plane, I cut the traction membrane. Now you can see there is a pre-existing tear just within the fold of the retina. I used forceps here to see the condition, and then I was trying to remove the PVR from the surface of the retina as much as possible. After removing the traction membrane successfully from the detached retina, I also removed the traction membrane from the optic discs also, and without harming the blood vessels. When I finished remove the traction membrane, I found there's a PVR change in the center of the macula. You can see that it's a little bit hazy in the center due to the cataract in the posterior pole. I used my forceps to remove the PVR from the center of the macula. Very gently, very slowly, cautiously, I did that so I could not harm or made any tear in the macula. After removing the PVR, I found that there is a subretinal band in the temporal side. I did retinotomy through the cautery. I made a hole and pulled the subretinal band with the forceps vertically, so it did not increase traction through the side of the retinotomy. So it did not increase in size. After successfully removing the subretinal band, I I I, I drain the thick subretinal fluid through the pre-existing tear, and after removing the thick subretinal fluid, I decided to do air fluid exchange. You can see there's a steel fold within the macula, and when I was trying to do the air fluid exchange, and I was removing the thick subretinal fluid through the pre-existing hole. Luckily, when I finished my air fluid exchange, I found macula settled down. And you can see there's a flat retina within the posterior pole. And after that, I did laser through the retinotomy and pre-existing hole. After finishing my laser, I put silicone oil inside the eyeball. So my main question here is that there is a PVR in the center of the macula. I tried with forceps but could not remove fully. And what could I have done to differently from that? Or did I do the right thing?
Thank you, Dr. Irene, for your nice video. So congratulations for showing us these two videos. So I think we can go for discussion now. So before going to discuss on Dr. Irene's video, I'm seeing here many questions. So I would like to request Dr. Swarup Sinha first to answer a few questions. Like if I'm reading here, Dr. Shahanur Hassan is writing what to do for subsilicon bleed in diabetic cases. Should we go for immediate removal or wet? This is one of the question. And again, Dr. Bilal Hussain has written here, is there any role of the preoperative peripheral laser in cases of visibly attached retina with added? And Dr. Sabrina has also put another question, could buccal implant help in the case of peripheral RD with the added cases? I think this question already been answered. Still, I'm requesting Dr. Swarup Sinha, please.
The first part, I'm assuming that post TRD surgery for a diabetic, there is a bleed under the silicone oil. Depends on the amount of oil, how much of areas retina is covered, how well you did the surgery, how much of prolif you had removed, and the eye intraocular pressure. If the IOP is maintained and the oil is there inside the eye, and you don't want to disturb very quickly, but this justification of when to go in second time is cannot be waited for very long. If the blood is not getting absorbed, start getting less, maybe at a month's time you can go in at that time and remove the blood, but it's a very variable answer. Amount of blood, intraocular pressure, where the blood is, how much of prolif you removed, and if you think you're in a very good surgery, probably you can leave blood for a little longer time. Second question, Dr. Bilal's pre-op laser. Yes, I answered that. If you can find retina, do the pre-op laser. Belt buckle, we are becoming very lazy nowadays. I use that word again. We are becoming very lazy nowadays. I have a little higher threshold, lesser threshold for belt buckle. I don't know, Rupak and me are partners here, but his threshold for belt buckle is very high. I tell him to put belt buckles very easily. I am little old-fashioned and I feel comfortable. Maybe I'm wrong. I'm not justifying that. Before I So I'll quickly, the two cases, I think, let me make 3 points very clearly. One, when you have a bad diabetic, we commonly say this nowadays, cutter is enough. No, I accept cutter is enough. We are brilliant surgeons now. We have brilliant machines with us, which makes us more brilliant surgeons. But please accept the fact that there are certain small steps where a curved scissor might help you or a forceps might help you. So don't throw it out of the window right now. Keep it there with you. I will again insist what Dr. Nia said. We pay more than £1 crore for a machine for the microscope. You magnify, even here, both the cases, there was hardly any magnification. And I have in the last 4 to 5 years started using a central contact lens for all macular-based surgeries. So in the second case that Irene asked, I couldn't remove the mic from there. What I would do is make very high magnification, look at inside the arcades only, put a little bit of dye, stain that area, a brilliant blue dye, stain that area, and then peel the membrane from there. You'll see wonders with these contact lenses, not with a microscope. I'm not talking about the ReSight or the bio, I'm talking about a contact lens on the cornea, which gives you a very good three-dimensional view. I've started using the last 3-4 years, mind you, doing surgery more than 20 years now, but I've changed my procedure last 3-4 years. I am very quick to put in the contact lens, and these are stabilizing, self-stabilizing. You don't need to switch them there. Quickly again, subretinal galactic bands do not need to be removed in most cases. It's a fallacy. It's something that we as surgeons have an ego. We want to remove everything from there. Most bands will just settle down when you do an FGE and leave it there. There's no necessity to touch it over there, especially it's nasally. What are you going to do with that? If you do an FGE, 3-year break, if it settles down, leave it over there. Even the peripheral one over there, leave it there. If your macula is going to dented, the retina is not settled down, definitely retinotomy and pulling it out. That's all I have. I also use the MVR blade when I'm doing this very dirty diabetic patients. Before going with my cutter, I touch with the MVR blade a little bit, like Niaz bhai said, don't pull from the disc. I go over there with the MVR blade, move it over a little bit over there, see what's happening. Put in my soft tip flute cannula, my soft tip cannula. I don't know if I'm making sense. The soft tip cannula and the flute, with the plastic part of it, just touch the membrane over there, remove a little bit of blood, see how tough it is, see how adherent it is, and then move with surgery itself, not with my cutter directly. Thank you.
Hello.
For this nice
phone
may I request Dr. Rupak Kantibishas to put your comment on this video? Can you add something as
yeah, this is an excellent cases and challenging cases, obviously. And the question what she has asked during her surgery is how to prevent enlargement of the retinotomy when you are taking out subretinal band. The most important is that here the shake hand technique will be the most easy way of doing it. So you go very close to the retinotomy site, and with both the hand you take shake hand technique, you take out those, gently pull it out. The moment you go out, see, suppose if you are having if you are pulling it and your retinotomy is here, if you try to pull it, the more you go away, your the distance from here, it is increasing. So your diameter of between it is like a funnel kind of thing, a point of, so it is increasing gradually. So obviously that portion also will tend to increase. So if you go close, if you work close to that, so that is one tip. So other, I think Dr. Sinha has well covered. So any specific question is there, then I can answer it very well.
Okay, thank you very much for these good tips. I think Dr. Irene question answered well. So I will go to now. Thank you, Dr. Rupak. If there is no other.
Just one more tip I would like to give. That there is one fluid exchange, what we call. So you have a long-standing retinal detachment. So before going ahead for directly into the fluid air exchange. So before that, what we do is the fluid exchange. So yes, that means the thick fluid what you take out, and then you do the fluid air exchange. So that causes the macular area settles down much easier way. Otherwise, those thick fluid will tend to settle down under the macula, and that area gets macula takes a little longer time to get settled, though your breaks are closed. Third point is that if you have a peripheral break, peripheral PVR changes. So once you start doing PVR, if you do fluid air exchange, and that point of time, if you see some air has entered into the subretinal space, so that means your peripheral traction is not yet been released completely. So the area where the break, the air has entered into the subretinal space. This is again try to put your on, mark that area, and again try to relieve the either subretinal or preretinal, or it may be an intraretinal fraction. So if you have due to preretinal or subretinal, try to remove those PVR membrane. And if it is intraretinal, then you can't help. Then you need to do a retinectomy at that area.
Thank you, Dr. Rupok, for your nice comment, but I didn't get your second comment. What you were telling about the fluid exchange, I mean, from the posterior pole, fluid exchange or then air fluid exchange.
No, what I mean to say, see, if you have a thick fluid, and if you do take out those fluid, the thick fluid will tend to get settled down under the macula.
Yes.
So if you directly do
what if I may intervene, sorry.
Yes.
What Rupok is referring to is a thick
subretinal
fluid. Subretinal fluid is very thick.
Yes.
In diabetes, long-chain diabetes, high protein content, what he's referring to is put your fluid over there, take that fluid out for quite some time. So your fluid is still on, not air. The fluid is, that is what he's referring to, fluid exchange.
That thick fluid will come into your thick of
yeah. So the thick fluid under the retina will come out, and that will get replaced with the BSS. Then your fluid air exchange becomes much easier.
Thank you very much for this very nice tip. Thank you, Dr. Again. So I'm seeing here that our senior retina specialist, our teacher, Dr. Ansarul Haq, is there. So I would like to take this opportunity to ask him to put any comment on this video. Dr. Ansarul is the senior most vitreoretinal surgeon in our country, and he was the first president of the Vitreoretina Society. Dr. Ansarul Haq, welcome, sir. Please.
Thank you, Nazman. Can you hear me?
Yes,
Can you hear me?
Yes, yes.
Okay. Thank you, Nazman.
Go ahead.
Actually, I didn't see. I was in another webinar. I couldn't see the last case or last two cases. But anyway, I first of all, I congratulate all our youngsters for doing very good surgery. I think they are coming up very well. And also to Dr. Shoaib Sinha and Dr. Rupok, for having them in this webinar. They are sharing their expertise, experiences with our youngsters. I think this is benefiting them, and in the long run, with these experiences shared by them and our panelists, the experienced surgeons, they will be coming up in due course of time. So for youngsters, I would always say that don't panic. As you go on doing more and more surgeries, you will come across many complications, and you will develop your own way of coming out of these complications. You'll find out your own techniques, how you will come out of these complications. So don't panic. So the more and more surgeries you do, you learn things. That is very important thing. And secondly, you take tips from your seniors. They will give you all the tips, like Dr. Sinha, Dr. Niaz, Dr. Rupok, Dr. Tarek, all of them are sharing today. So this will go on continue, and I hope it will develop fast. As for the surgeries, I've seen 2 or 3 surgeries, the initial ones, like these choroidal detachment and all. So in these cases also, I think there are ways of what Dr. Niaz has said, that you first form the eyeball. Because when there is a choroidal detachment, the eye becomes soft, and it is very difficult to put the cannulas or other instruments in the eye. And there is always chance of complications, even hemorrhage. So always ensure that you make the eye firm, increase the intraocular pressure. There are techniques, like Dr. Niaz has showed. You go through the needle to the center of the eye, if you can see the pressure, check the pressure with the digitally. Even if you feel that you cannot go inside the eye, you can even use the AC maintainer. It is also a very good instrument to maintain your intraocular pressure. In pseudophakic eyes, it is very easy. Just put the cannula AC maintainer, and you just see the IUP goes up and down, then you can infuse the cannula. Even in phakic eyes, you can do it, but you have to be very careful that you don't damage the lens. So you have to have a control over the AC maintainer. That is another way of doing things. So there are a lot of ways that how you can do things. and it depends on how you can manage the case when you are doing the surgery. So you learn these techniques as you go on doing surgeries, so it will be okay. So similarly was the case when the hemorrhage, in which case, I don't know, Varana's or Dr. Malia's, I think there was hemorrhage during vitrectomy. So in that case also, I think she hasn't done complete that was the case, I think. She hasn't completed the vitrectomy, I think, peripheral vitrectomy, so that thing should be taken into account because these vitreous, if it is in the periphery, they are cause of recurrent retinal detachments. So take time, if you want to take time and complete your surgery very carefully and don't panic. So these are some of the things that you will learn as you go across doing more and more surgeries. And of course, I think Dr. Shorab, Dr. Rupak, and others from across the border, they are always with you. They are always helping with their experiences, their new techniques. So this is how you will develop. And I think by this time, the surgeries that you are doing excellent job. Thank you.
Thank you, sir. Thank you very much for your valuable comments and tips and advice to the young retina specialists. Thank you very much once again. So I think we are running short of time and almost close to the program. So I'll before concluding, I am to read one comment from Professor M.A. Bashar Sheikh. He has written here, I feel eyeball is soft before introduction of the trocar. If eyeball is soft before introduction of trocar, we can inject BSS by 30 gauge needle in pars plana. Thank you very much, sir, for your comment. I think this point has been discussed. Thank you very much. So I think I should thank to all my presenter, but our session will be concluded by our president of Vitreoretina Society, Dr. Niaz Abdur Rahman. Before concluding, I want to thank from my side, thank to all the presenters, thank all the learned panelists. I believe our youngsters are doing very good. We are impressed, and I believe we can do this sort of webinar later on and continue this type of things, and we can learn from each other. From this sharing and learning technique will be good for everyone. So thank you once again, and I want to thank Dr. Aristo Pharma also for being with us. Now the floor is for our president, Vitreoretina Society, Dr. Niaz Abdur Rahman. Please, sir, conclude this session, and if there is any comment you can put. Thank you very much.
Thank you, Najman. Thank you very much. I think we had a very nice session. What do you think, Saurabh and Rupa? Do you think it was a good learning session for youngsters?
I'm so happy. I'm so happy Rupa put me for this. In Shagaratila, we had this thing of being an outstanding surgeon. So there are two definitions, let's say. One is outstanding means you actually do surgery which is very good and it's very, very high quality. The other is outstanding means the joke was the consultant would stay outside the OT and the fellow would keep operating. So that's an outstanding surgeon. And I would tell the fellows, I'm not going to be outstanding, I'll stand right next to you. So I love the interaction today. If it may pull me back to old days again. I really want to thank Tariq sir and all of you there at Bangladesh for having us over. I'm always available. I really thank you all for having us. An excellent presentation. It's difficult at this age to show your complications and you know, people commenting on you. It's really all four of you congratulations. Thank you so much, all of you, sir.
Thank you, Saurabh. Thank you, Saurabh. Thank you, Rupak.
This is really, sir. This is, I mean, really with folded hand. I'm just telling that awesome organizers. The way you have planned. Special thanks to you, Dr. Tariq and Dr. Zia. This is really, I mean, the practical tips. That's what exactly the young generation they wanted to know, not the didactic lecture as such in a different way. But this is how exactly we can, you know, improve our discussion. Thank you so much, sir.
Thank you. So I'll be concluding, but just I want to give two tips for our last presenter, Dr. Irene Hussain. You see, in the first case, there was a lot of blood in the posterior pole. Now, my personal thing is I must see my retina where it is.
So I try to clear out as much blood as possible before I do vitrectomy. Whatever I do, I don't let the blood stay in the posterior pole. I will blow it out, blow it out with the flute needle and suck it out and wait. I'll try to see the retina as much as possible. One tip. The second tip about the enlarging, Rupak has said that, I don't want to go into it. He has said very nicely how you can prevent an enlargement. And the last comment I want to make, Dr. Irene, is that macular pucker that you couldn't remove with the forceps. As Saurav was saying, you stain and you do an ILM peel from the little bit of the periphery. ILM to peel, the macular pucker will automatically come out. So you try doing an ILM peel in detached retinas. Also, if it's a long-standing detached retina, make it a habit of doing an ILM peel if required under PFCL, which is very easy to do. Then post-operatively, you never get a macular pucker. Those are the two comments for the surgeries. Thank you, all four of you. Wonderful surgery. I'm sure the next time we will not get you in this because your surgery will be in a higher plane and we'll get more younger people. Okay, congratulations, four of you. And congratulations, Najmun and Tariq for really arranging it. Ansar Bhai for coming in, Zia for being here. Aristo Pharma, I really want to thank you from the bottom of our hearts. You've been always with us, helping us. Thank you, Aristo Pharma. And I want to thank all the participants who had over. Our Vitreoretinal Society is a society of 40 plus members, and we had over 40 participants, a few outsiders. So I think 80% of our VR people from the society joined in. So I'm very happy of this program. Thank you, everybody. Have a good night and see you soon. We'll try to, in a few months, not very quickly, we'll in a few 3-4 months, we might arrange something again. And Saurav and Rupak, both of you will be invited. Thank you very much. Bye-bye. Good night.
Thank you so much.
Good night.
Thank you so much.
আবার
ডাকবো কিন্তু আবার আসতে হবে।
I'm always there.
Thank you very much for your.
Thank you.
আসলে খুব চমৎকার সেশন।
Well moderated, Dr. Nazmun, very well moderated. You have big shots. When you have big shots to handle them, it's not easy at all. So it's a good job. Well done.
Thank you, sir. Thank you. We have learned a lot. Yes, we'll call you again. We are continue to calling.
আজকে তো আপনারা বিজি ছিলেন, সপ্তমীর দিন ছিল, তারপরেও you have taken your time for us. Really amazing. আপনাদের নিজেদের সময় আমাদেরকে দিয়েছেন। Thank you so much.
Thank you so much. Yes.
Thank you.
Thank you. All presenters have done well, and actually, yes, it's nice.
Good night.
Thank you. Yes. Good night. Good night. Good night, Tariq bhai. Yes, দেখা হবে ইনশাআল্লাহ। আসসালামু আলাইকুম। সবাই ভালো করছেন। Thanks. Finally.
Thank you, Appa. Thank you.
Thank you, madam. Thank you. আপনার অনেক অবদান আছে, কোনো কিছু হইতো না। প্রথমে খুব ভয় লাগতেছিল কি বলতে পারবো কি পারবো না।
এবং সবাইকে সুন্দর লাগছে। আনসার স্যার, আপনি আসেন, কিছু বলছেন। থ্যাংক ইউ ভেরি মাচ স্যার।
থ্যাংক ইউ
স্যার। পরে ঢুকেছেন স্যার।
না, সবাই খুব ভালো সার্জারি করছে। আই এম ভেরি হ্যাপি।
Thank you.
Thank you, স্যার।